Oh, thank you, Kate and Nikki, for giving us the opportunity to speak about our MDT. So I'm Christina Nuttall. I'm a nurse clinician, or more recently, an advanced practitioner is a new name for us. And I've worked on the team, it's really scary, 14 years. So Melissa and I specialise in neuroendocrine tumours. We also cover hepatobiliary cancers as well, and I do upper GI cancers. So we've been very fortunate that Melissa has joined the team recently. She's not new to the team because she was a clinical fellow on the team. So some of you might remember her from about 4 or 5 years ago. So what the aim of this talk is I'm going to talk about what an MDT is, and specifically what our net MDT means. I'm going to talk about who sit on the MDT, what patients get discussed, and what determines patient decisions about treatment for patients. And then I've got a fictional MDT case that I'm going to discuss with you. And I know some of you have already sent questions in, which we can answer at the end, but hopefully through the talk we'll be able to answer some of the questions. Melissa, how do I move this? We're having technical issues. Just moving this on. Okay, so this is a recent picture of our MDT a couple of Fridays ago. So at this MDT, we've got radiologists, we've got consultants, we've got myself here, Melissa here, some junior doctors, GPs, but what you don't see is people who are linking in on Teams. So we have consultants from outside hospitals who link in. So the net MDT at the Christie started about 15, 16 years ago in a broom cupboard. And that was started by Professor Valley and Dr. Manoharan. And at the time, really, I suppose there wasn't that much interest in nets, not as much as there is now. And in March 2011, the Christie got the accreditation for the Centre of Excellence, and then it was boom. And then we got this nice MDT room that takes place every week, every Friday. So to me, this older MDTs are different, and I'm biased about our MDT, but I think this MDT is great. We've got people who are fantastic and passionate about nets. So the NHS England defines a multidisciplinary team as a group of health and care staff from different organisations and professions who work together, who make decisions regarding individual patient needs. To me, I suppose it's a mixed discipline of health professionals who are passionate about the patients, the disease group, who want to ensure the patients receive safe, effective treatment and that is tailored to their needs. So the MDT members, and this is in no particular order. So our MDT, we have an MDT chair, and that's always a medical oncologist who specialises in NET, and they alternate each week. So we have 4 medical oncology consultants. Hopefully we're going to get a 4th one to replace Prof. Valley in the near future. And they kind of organise us, keep us in hand, really. We have the MDT coordinator. So the MDT coordinator, they do all the admin, they put the MDT together. People from outside hospitals will refer in, and they ensure that all data is documented and accurate. So their role is vital. We have a histopathologist. So every MDT, we have a histopathologist. So we have a couple at the Christie who are specialists in neuroendocrine tumours. So all patients who get referred in, we always get a second opinion on the histology. So sometimes that can be the delay in patients being discussed at the MDT. We have radiologists. So we have a radiologist who will sit at the computer. You saw on my picture, he was sat at the computer, puts the imaging up and goes through, identifies where the primary is, the burden of disease. We also have the nuclear medicine team who sit on the MDT, and that's when we're asking questions about the PRRT. We've got medical oncology, so there's always 2 medical oncologists who sit on the MDT. We have an endocrinologist, so Dr. Saf Adams sits on our MDT when we have all our complicated endocrine questions to ask. And we have surgeons, so we have a liver surgeon who sits on the MDT, and at request he'll be present. And then we have our colorectal surgeons who sit on our MDT every week. And I've put cardiologists, so the cardiologist doesn't necessarily sit on the MDT every week, but at request they will link into the MDT. So that's if we're worried about patients with carcinoid heart disease. And then we have gastroenterologists. So we have a consultant from Manchester Royal Infirmary and a consultant from Wythenshawe who link in. And then we've got junior doctors who rotate. So they rotate every 3 months. We have GPs. And then we've got the nurses, which would be myself, and the clinical nurse specialists, who some of you might know, Kelly and Natalie. So what patients get discussed? So any new patients who get referred in. So again, that's we're waiting for the histology to be reviewed. Often we're waiting for images to get imported. So sometimes that can delay discussions taking place. So patients who have, so our existing patients, so you wouldn't necessarily discuss every single patient in clinic who has changes on the CT scans or has symptoms, because it might be obvious after discussion with your team in the clinic what the plan is, but sometimes the more complicated cases, you might run them through the multidisciplinary team to get an opinion. Yeah. If a surgical opinion is required, so sometimes, for example, if a patient's had chemotherapy and the cancer's reduced, you might want to ask the liver surgeons, is the liver lesions resectable? Is the pancreatic lesion resectable? But sometimes you might have patients who have symptoms of intermittent bowel obstruction. You might want an opinion of our colorectal surgeons about that. Second opinions where appropriate. So we often get lots of second opinions from outside because we cover Greater Manchester, but we get patients referred from Wales, Cardiff, Newcastle, Scotland. And then their cases will be discussed and the opinions will be referred back to the treating team where they've been referred from. So the Christie MDT. So our MDT is weekly. So it's every Friday morning at 8 o'clock. Which I've been sat doing that for the last 14 years. We have a maximum of 10 cases. And cases are presented. So what happens is the MDT coordinator will send out the list on a Wednesday, and I go through the list, and I would divvy out the patients to be discussed between myself, the junior doctors, sometimes the clinical nurse specialists. We have, if pathology needs reviewing, we have the histopathologist who will review that. We review radiology, and we discuss options, including intervention and treatments, and make recommendations. So if it was for a second opinion, the recommendation would get sent by the MDT coordinator to the treating team. And for our patients, we would discuss it in clinic, and there is an option to have a copy of the MDT outcome if requested. So what determines decisions? So there's lots of things that can determine decisions. So histology, so the grading of the neuroendocrine tumour. So if it's well differentiated, if it's a poorly differentiated, treatment is very different. Sometimes when we have patients with cancer of unknown primary, the histopathology can give us an indication of where the primary is, and that can give us guidance on what treatments we can offer. Radiology, so the radiologist can let us know about where the primary is and what the burden of disease is. And fitness, so at the fitness of the patient. So it's all very well saying, well, the patient's got a neuroendocrine tumour, and the treatments are what we recommended, but if the patient's not fit enough, what you don't want to do is give a treatment that's going to affect the patient's quality of life. So when we're looking at fitness, we look at something called the ECOG performance status. So that's the Eastern Cooperative Oncology Group. So we look at, 0 is very fit, up and about and active, 4 is bed bound. So if you've got a patient who is spending more than 50% of the day resting, it's unlikely that they will be fit enough to have chemotherapy, for example, because the risks outweigh the benefits. Other things we consider is the comorbidities. So we would look at if patients have got a cardiac history, you would be worried about offering treatment like capecitabine because it can have effect on your heart and can cause problems with angina and heart attacks. So you need to that can guide us. The other things we think about is blood tests. So we would look at renal symptoms. If there was any problems with the biochemistry, we would worry that some chemotherapy, some treatments can be toxic to the kidneys. So what you don't want to do is give the treatment that's going to make the kidneys worse. Also, we consider obviously evidence and what is available, and if there's any clinical trials that are opening. So often they open and close. There's not 1,000,001 clinical trials for neuroendocrine tumours, but we've had a few, haven't we, over the years. We also think about the early experimental medicine team, because often they may have something to consider as well with clinical trials. And we also think about symptoms. So when I say symptoms, if a patient's got carcinoid symptoms, one of the things you wouldn't be able to consider is everolimus, because it's the recommendation you need to is for non-syndromic patients. And you'd also consider response to previous treatment. So if a patient has had a CT scan and it shows that there has been progression of disease, you may look back at previous treatment, and if it was a while ago and they responded well to it, you might think about re-challenging with that chemotherapy or treatment. And I've said about previous treatments. So when I say previous treatments, you might, if you're thinking about starting some chemotherapy and they've had previous chemotherapy, you might think the effect it has on the bone marrow. So you might need to think of future treatments reducing the dose so it doesn't affect the blood counts. So this is the clinical case I'm going to discuss, and it's made up, it's a fictional, but it's similar to what we discuss most weeks. So this is a 62-year-old female, non-syndromic. Her ECOG performance status was 0, so very fit, up and about, active, normal activities of daily living. Past medical history of high blood pressure and diabetes, both of which are very well controlled. And she was taking some blood pressure medication and some diabetic medication. She was a non-smoker and occasionally drank alcohol, and no significant family history. So the patient presented initially just routine blood tests and was found to have deranged liver function test, no symptoms whatsoever, and that led to further investigation. So that led to a CT scan and a PET scan, and unfortunately the patient was found to have a pancreatic lesion with nodal involvement, so lymph node involvement. The patient went on and had a Whipple's resection, and the histology from that revealed a well-differentiated grade 2 pancreatic neuroendocrine tumour. So the Ki67 was 8%, and the staging was a PT3N1 R0. So what that means is a T3. So when you're looking at this, when we're after an operation, you're looking at the staging of the cancer. So T stands for tumour, N stands for nodal involvement, and M stands if there's any metastatic disease. So a T1 is if the tumour is less than 2 centimetres. A T2 is if the tumour is 2 to 4 centimetres. T3 is when the pancreatic lesion is more than 4 centimetres, but it's confined to just the pancreas. A T4 is when the tumour grows outside the pancreas. So the N1, so the nodes involved, so an N1 is when there's 1 to 3 lymph nodes involved. So the patient was discussed at our Friday Net MDT in August 2019, and they had post-operative imaging, and that showed there was no evidence of recurrent disease. So for completion, so often, after patients have had this surgery, the recommendation will be to have an MRI scan for completeness. So I've just popped on just for us to just look at the gradings for the nets. And so this patient was a PT 3N1 with a Ki67 of 8%, meaning it's well differentiated, indeterminate. So going back to the patient, so the patient had the recommended MRI liver, which showed small liver lesions, possible metastases. They'd had a gallium scan. On the gallium scan, the liver lesions were not visible. So the MDT again, the recommendation was to start some lanreotide as a holding measure, because the hope was that this patient was going to go and have a liver resection, which they did. So in January 2020, they went on and had liver surgery. And interestingly, the histology from that revealed a grade 2 NET with a Ki67 of 4%. So April 2020, the imaging revealed no evidence of disease, and the lanreotide was stopped, and the recommendation was for surveillance. So following on that, they carried on with the surveillance imaging, and unfortunately, when they had the next scan, an MRI scan, it revealed progressive liver disease. Surgery was ruled out, and the lanreotide was restarted. So in May 2021, so 9 months down the line, the patient had further imaging, which showed that there was further progression. They had a gallium scan, which showed varying degree of tracer uptake. So I'm going to show you a picture of the gallium scan. So this is pre-tracer. So you see the little arrow here, it's showing the liver metastases. So post-contrast, what you would expect if it was gallium avid is for this liver lesion to light up like a Christmas tree, so to be brighter than the surrounding liver tissue. But unfortunately, in this case, that was not what was seen. And the worry would be to give, if PRRT is not likely to be effective if we were to treat in this situation. So the recommendation was to give everolimus. So just to recap, a 62-year-old lady, background history of hypertension and diabetes. It was well differentiated, indeterminate grade 2. They weren't syndromic. The primary and the liver metastases had been resected. They'd been preloaded with lanreotide, and now there was progressive liver disease. And we said, what are the options? And we've said, Melissa, I'll hand this over to you.
Yeah.
So why was the PRRT not recommended?
So the recommendation for PRRT is for patients who have received previous treatment with somatostatin analogs, like in this case with lanreotide, but they need to be gallium positive, meaning that the lesion should have increased uptake, so higher uptake of gallium than the background liver, which is not the case of this patient, because we saw from the previous images that Christina showed to you that actually the metastasis in the liver had no uptake whatsoever. So if the lesions in the liver, the tumor lesions across the body, most of them are gallium negative, as in this case, PRRT wouldn't work. So we will only give toxicity to patients. So that's why, unfortunately, it wasn't recommended.
Okay, so why did we choose everolimus?
Yeah, so a second line options for patients with pancreatic NET is everolimus, which is a targeted therapy. And everolimus is given in the form of tablets and is given on a daily basis. So for patients with pancreatic NET after somatostatin analogs, we have a number of options. This also includes sunitinib, for example, and PRRT, which we couldn't pick in this case, and also chemotherapy. So the choice between everolimus, sunitinib, which are two targeted therapies, versus chemotherapy is based on how aggressive the tumor is. So this is a tumor that within the intermediate grade NET, it didn't look at this stage particularly aggressive. We didn't have high volume disease. So in these cases, we go for a targeted therapies. If it was a case which would appear more aggressive, and maybe with a Ki-67, a proliferative index a bit higher than 10, for example, or even higher than 15, and with more disease burden, we would have chosen chemotherapy. So in this case, we made the choice of going for targeted therapies. Now, between everolimus and sunitinib, the choice is made based on the toxicity profile. Everolimus causes hyperglycemia, so it can make the diabetes worse if someone has diabetes, and sunitinib can cause hypertension, so it can make hypertension worse for someone with high blood pressure. So this patient actually has both hypertension and diabetes. So both of them are well controlled. So in this case, whether it was everolimus or sunitinib, probably in terms of toxicity profile and risk, it wouldn't have made a big difference. So we went with everolimus, but obviously keeping a close eyes on the glycemia of this patient. We could have gone for sunitinib and keep a closer eyes more on the blood pressure. So that's why we picked everolimus. If it was a patient without diabetes, we would have chosen everolimus. If with a patient without hypertension, we would have chosen sunitinib.
Okay. And with everolimus, the main side effects that you would expect to see with it is mucositis, so soreness to the mouth, or stomatitis. You sometimes get a rash, fatigue. There's a risk of infections with it, and on the trial is at the 5% risk of hyperglycemia, so it's relatively small, and the patient was well controlled. And we've said what other treatments. So just to recap that, we can think about as future treatments, sunitinib, which is, Melissa said, an oral targeted treatment that patients take once a day. You can consider temozolomide and capecitabine, so that's chemotherapy, and it's two oral tablets that you take 2 weeks on, 2 weeks off. And other things to consider is clinical trials, or we've got the early experimental team, the phase 1 team, that we can always consider to tap into. And I think we've covered that, really, future options to be considered.
Another option that it is available, it probably doesn't apply to this case because the patient wasn't syndromic, is what we call liver-directed therapy. Mainly chemoembolization. So in patients with liver metastases, when there is, disease burden, important disease burden in the liver, especially when they are syndromic, we treat the lesions in the liver, and it helps keeping the tumor under control, especially if the liver lesions are the main site of progression, and it also helps with symptom control. It wouldn't be probably one of the options on the table for these patients, but it could be in patients with symptoms.
Yeah.